Okay, next up is Ross Juergens, who's going to follow up on systemic therapy being all you need. We could have Dr. Juergens' slides, please.
So our second half of this debate, again, total neoadjuvant therapy is feasible. I didn't say we're replacing rad-oncs and surgeons, but the concept is feasible that early stage lung cancer patients could live lives without surgical or radiation approach. So when I was given this topic, I honestly sat here and I'm like, gosh, I feel a little bit like this picture of little David and the big Goliath. And then after looking at the surgeons who practice in Montreal, I really understand where Goliath has come from. And you know what? When I was debating, I thought very closely about my surgical colleague here, and I thought of the Tomb Raider and her knives, and then I saw this picture of my colleague, and I was like, damn, this woman could take me in a fight, so I better be careful as to how I approach this. And then I started thinking, oh my God, you know what? The rad-oncs, maybe they don't use, my surgeons don't use knives anymore, they use robots, and then all of a sudden I went down the rabbit hole of the Terminator, and then I found this picture of my colleague in Hamilton with his fancy-dancy robot, and they totally look like a street gang sitting there with their arms crossed, all looking like they're Mr. Serious and coming for you. And then I thought about my colleagues in radiation, and David Palma always has to throw in a lightsaber reference whenever he gives a talk, and there's, again, my colleagues in radiation, you know, the Lords of the Sith, as they are, who are going to have no toxicity radiating my patients. So when I started to try to figure out how I was going to tackle this debate after I got over my fears of lightsabers and robots and knives, I decided to take a look and see what literature was out there. And lo and behold, instead of ChatGPT or Wikipedia, I went to the National Cancer Institute. I would argue a pretty reputable group to actually read about. And this was an article that was in the February 2023 issue. Immunotherapy and nothing else. Studies test potential paradigm shift in cancer treatment. Normand showed you some data in bladder cancer. You've heard from the surgeons that there's also data in esophageal squamous. I'm going to show you some data here in colorectal cancer. This was a study by a friend and colleague, Luis Diaz, who actually looked at PD-1 blockade and mismatch repair deficient locally advanced rectal cancer. And as you can see here, I actually got phone calls from patients asking if they could get dostarlimab after this publication when they saw 100% response rate to treatment with these immunotherapy agents. There was a second trial that was done. Actually, this one was at MD Anderson, you know, but like, who wants to trust anything that comes out of one of those sketchy institutions. So this was looking at neoadjuvant pembro and localized microsatellite instability in mismatch repair solid tumors. Again, some of the patients got surgery, some of the patients chose a non-operative approach, and again, these patients actually were able to be spared surgery in this scenario. And then one more, a personalized response-directed surgery and adjuvant therapy. This was a melanoma trial, just one more example of how we can actually modify what's being done and sparing melanoma patients these lymph node resections that can come with toxicities like lymphedema that will plague that person for the rest of their life. So, you know, can we do this in lung cancer? And I would argue that what we need is good biomarkers. And we heard an elegant talk yesterday from Elsa talking to us about how we are continuing to make progress. And I do believe that we are going to even further diagnose our patients. It's not just going to be EGFR and ALK and PD-L1, but we too will be able to find biomarkers that allow us to predict who can benefit from just systemic therapy alone, who might need an operative approach, who might need radiation. And I think that future is not necessarily 2054, but might be sooner than we realize. So as I pause one more time, feeling a little bit like David looking up at Goliath, I decided to reflect one more time on the people that I have impacted and those most difficult, not our early stage, but our late stage patients. And dang it, I spent an hour trying to embed this stupid video. So if you Google immunotherapy, how a former cop beat cancer, you'll actually find a video on the Wall Street Journal, of all places. And this is the story of David. This is my David. So David was the last person I referred for clinical trial before I left the US and moved to Canada. David participated in a clinical trial as a fourth-line option for his metastatic lung cancer. He had failed platinum doublet, he had failed taxane, he'd failed epigenetic therapy, which was my PhD thesis project. He participated in that clinical trial and then participated on the clinical trial that eventually became nivolumab. David was a 14-year lung cancer survivor, had 2 years of immunotherapy, had 12 years of good quality of life. He actually passed away, not of lung cancer, but of something else. So systemic therapy can cure, and I will say that I do believe we cured David of his lung cancer in stage 4, where they have huge bulk of disease. I think we can overcome early stage disease with systemic therapy. And who better would you want to listen to
Get that slide from.
when you see these slides that come into slide decks when I collaborate with friends and colleagues, but no better than our chair.
That's it.
So, merci. Thank you very much.
All right, bringing it home, Dr. Drew Moganaki from UCLA is going to show us the radiation oncology side of cure. Thanks, Drew. Tough act to follow there.
There is a lot of energy in the room. My gosh, initially, I thought you don't want to debate Americans. Now I realize you don't want to debate females. Okay, so let's bring this home. Dr. Antonoff is competitive. She wants to win, and so that's my objective here. So let's stop for a minute and ask ourselves, what is wisdom? Wisdom is the quality of having experience, knowledge, and good judgment. It's the quality of being wise. What is conventional wisdom? Beliefs that are convenient, appealing, and deeply assumed by the public. Beliefs that are not necessarily true. And beliefs that generally oppose the introduction of contrary beliefs, sometimes to the point of absurd denial of new information. An example of conventional wisdom is that surgery is the standard of care for operable lung cancer. What is heresy? Heresy is a belief or theory that challenges conventional wisdom. And I would argue that could be such as local therapy can be omitted for stage 3 lung cancer. But heresy can have value. Here is Dr. Nasser Al-Turki giggling with me after I asked him how did he deal with 17 years of judgment that lobectomy wasn't the standard of care. And he said, I've got some pills I can share with you if you'd like them. Now, what is reality? Well, surgery and radiation therapy can eradicate trillions of cancer cells. It's a treatment that's targeted, minimally invasive, and the side effects, as described, are localized and generally temporary. And the non-path CR rate after neoadjuvant or total neoadjuvant chemoimmunotherapy right now is 75%. And if treated with TKIs, probably 90%, and perhaps with ALK inhibitors, maybe 65%. That's a lot of patients with incompletely eradicated disease. And horrible outcomes can occur with uncontrolled disease. This is one of my favorite patients, and unfortunately, we are now dealing with this because Pembro has been unable to control her disease. And just notably, side note, I work at an institution that ran the first KEYNOTE-001 trial, where our medical oncology colleagues are very comfortable with systemic therapy alone. We don't see this too often, but this can happen. So uncontrolled disease leads patients to live with intractable pain. Depending on the location, the tumor can grow. Pancoast syndromes can develop. SVC syndromes can develop. The tumor can go through the neural foramina into the spinal canal. Uncontrolled lung disease can lead to hemoptysis, central airway obstruction, lobar collapse, pleural dissemination, malignant effusion, and eventual suffocation. Now, what is virtual reality? This is virtual reality, that if we look at the PathCR patients, we could have cured them with surgery. And the ones who didn't have a PathCR, well, surgery didn't help them anyway. More virtual reality from the chemo-RT side is that the progression rate was so high in the lower trial with chemo-RT alone that chemo-RT could have been omitted. Now, unfortunately, and it's by accident, she kind of looks like Mara here, but what is harsh reality? Harsh reality is a physician on the stand trying to explain why their stage 3 patient died and surgery or radiation therapy was omitted. I don't know how many in the room are aware of the White Ribbon Project. This is Heidi, who is the founder of it. She's a long-term survivor for stage 3A lung cancer treated with chemo-RT. And here she is just a month ago doing great. Would she still be alive without chemo-RT? Would thousands of lung cancer survivors currently alive after lung resection still be alive? It's not clear. So here we are, Dr. Antonoff, I hope I fulfilled your expectations, which is that I endorse the statement that local therapy will always be required. That is, until we can predict PathCR and that the drugs are safer. So at this point, we are ready to accept our prize. Thank you, John.
All right, very good. So that brings us to a close. Maybe we'll do a quick vote. Who thinks local therapy is still part of the equation and will always be? Oh, guys, you guys are so sweet.
Who thinks systemic therapy is an essential consideration for patients with localized lung cancer?
An essential consideration?
A consideration.
Oh, yeah, excellent. Consensus builder. Okay, so thank you so much for sticking out these 2 very full days of talks and discussions. I think we really, as you said, Norma, covered the gamut of what is going on in this space. And it still feels like there's a lot more that we could talk about. This obviously, nothing would have been possible without our sponsors. So I want to thank specifically our platinum sponsors, AstraZeneca, Bristol Myers Squibb, and Merck. Our silver sponsors, Amgen, Regeneron, and Roche. And our bronze sponsor, Pfizer, as well as the support of the Montreal General Hospital Foundation, which kind of backed us up through all of this. We've put up our dates for next year, Thursday, June 19th and 20th, so block your calendars. We'll do our best to get the program out to you guys as soon as possible. Slightly different location, but I think we'll try and incorporate a little bit more interactivity. I don't know if you have any thoughts to share, Normand, but I just want to thank everyone, all our speakers, from coming from so far. It's a tall ask, we realize, in the summer, as the summer's starting, and we just are extremely, extremely appreciative. Last couple of things, there's a bus to get you back to the hotel if you want. We have cocktails at the restaurant, which is not too far away, starting at 5, a nice raw bar and stuff available for you, and a nice dinner to follow. Last thing I want to say is huge thank you to Tash McLean and Angela Alston, who are really the heart and soul organizing this whole thing. They put an enormous amount of work into it, and so maybe a round of applause. And I'll hand over to Norm.
I think John deserves a round of applause for all the organization of this meeting.
All right, and thank you, Normand, for you mentoring me through all of this. I really appreciate it. So, okay, you're free.